Oh, you mean the question of Nuno on probiotics?
Yeah,
Is that the one?
Yeah. Or maybe we should take that question offline. I don't know.
I'm still reading it, but well, maybe there are other panelists that I was just speaking for the other questions. So maybe there are other panelists that would be happy to give an answer here.
Okay, I think it will Nuno and Joanna will park these questions for now. We come back later to these, and maybe an individual answer will be better. Okay. We have a follow-up question from Neil Stewart about the GalNet.
Our registry is for professionals, so the patients themselves cannot be entering or supplying their data. There is another registry for patients, which is from the Galactosemia Foundation in the USA. But if you would like to be in the registry, you can always contact your physician and let him or her know that and ask whether they are members of the registry.
We have a question from Natalie, and Natalie is allowed to speak, so you can unmute Natalie. There she is. Hi, Natalie. You've been asking questions, so I would like to give you the opportunity to join live if you like.
Hello, I typed the questions in the box. Hello?
Yeah, okay. So I thought maybe you would like to ask them personally to the panel. Annette, would you like to answer these from Natalie?
I'm trying to open them. I can't see them right now.
Sorry,
yes. Yeah, I can see them. Should all adults with classical galactosemia still get their GAL levels checked? If so, how often? Well, what we see is that most patients in young childhood come down from a high level as newborns. They go down and they find pretty much a stable level. And that means that we set in a guideline, well, yearly might be an option, or if there might be any changes in diet, and that's especially when your situation changes, you move out of the house, you go live on by yourself, you might consider checking it around that time to see if anything changed with your diet. But adults with a very stable GAL and P level, I think right now in the guidelines, the advice is yearly, but I think it's not necessary yearly if you're an adult and if you have a very stable level. That's the first question, I think. Then the second question is, if an adult follows the diet, could they still get seizures or tremors later in life if they haven't had any as a child? Well, seizures we don't see much or really. So the question is, are they related? But especially tremors we see. Many tremors are not hampering the ability of the person, so they don't really interfere with daily life, but in some patients they can. And if we look at the whole group of patients, we see more tremors at this time in adults than in children. That might mean that the incidence increases when you get older, that more people get tremors, or it might be that we're not aware enough of them in children and we have to look closer. So that is something that we will have to learn still, but there are people who have not really been diagnosed with tremors as a child, but may develop them when they get older. Then the third question, has any female stored eggs and had a baby from it? I hope Cynthia's joined, or maybe Estella is able to answer, because I think that's more their field.
I'm on. I think that as far as we know, no female has attempted to use eggs that they have stored. We've heard of several people who have stored either tissue or attempted to store eggs, but I am not aware that anybody has actually used them to become pregnant. I'm only aware of one case where they froze tissue and that woman became pregnant spontaneously from the other ovary. So if you do hear about this, we are very interested to learn. I hope that answers the question.
And another question from Natalie is there a correlation between mutations and outcomes? So the genotype, phenotype question.
I could give. Shall I start?
Maybe.
What
oh,
we.
Oh, yeah. Okay. No,
Go ahead.
Estella,
go ahead. Of course, we are aware that there are the classic mutations, and there's a whole line of them. And in these people with the classic mutation, the outcomes can be very variable. And it's very hard to predict who is going to have the better outcome and who is going to have the worst outcome. Then, especially after newborn screening, we sometimes find patients who have a milder disease, and they have usually a little bit different mutation and may have a better outcome, but these are still young. But for the severe mutations, it's hard to predict who is going to develop in what way. And I'm sure Estella would like to add something.
No, I was just wondering. I thought maybe Jerry would like to comment also on this question.
I think what gets things confusing for individuals is the fact that you can roughly separate galactosemia into 3 different types, with the idea that the least severe, or the one that's without disease, is Duarte, and then there's a variable type in the middle, where it seems, and this has not been well studied, where it seems that the majority of patients in that, although it's small, are not subject to long-term complications if they've been treated in the first few weeks of life. And then we have the classic group. Now, most of us focus on the classics altogether, but as Annette was saying, there really is tremendous variability in how the classics present. For me, it seems that the 2 most critical issues in galactosemia is the issue of the heterogeneity or variability in outcome on the one hand, and then also the timing of disease on the other. So, we have some patients with homozygosity for Q188R who don't have a tremor, and they're older. They've been on diet since the newborn period, and they really don't. You may not be able to at first glance see that they have real problems at all. And then there's others that, even though they've been treated from the beginning, have serious problems with MRI abnormalities that include brain atrophy. So I think one of the major problems in the field is to understand, why does one person have such significant problems, even though they've had the same kind of treatment as someone else who is relatively doing well. So does that help to answer that? Or? Was there more? Does that help answer the question or no?
I think so.
Okay.
I have a question that came via mail to.
Oh, Jeroen, you're on mute.
Jeroen, you are muted.
Yeah. I try to switch between my spacebar and my microphone. So I have a question here, and I think it's very relevant. And it says, I have an adult daughter. The diet already was assumed since childhood. She has bone mineral density and scoliosis problems, ovarian dysfunction, but these are small problems compared to the main one. The very main problem is always a psychiatric and behavioral disorder. When will the EGS address this issue? I understand that you always have to talk about diet, but this is the least of the problems in an adult galactosemic. I do agree. I think the diet, by the way, is also very important because it's the only thing parents can do. But on the other hand, it is really true that it is not preventing any other issues from developing or getting worse, maybe even. So as the EGS, we struggle a little bit because as a European group, all the activities and treatments and way of dealing with it is very local. So as EGS, we address it regularly to the GalNet, but we struggle a little bit with it, to be honest. So it's always on the agenda, but it's not so easy to answer. So, but maybe Professor Barry can answer on this or comment on this, because I'm not sure if there's an answer.
Well, you know, the adult study that we had done about 10 years ago that Cynthia and Estella had helped us with tremendously. That was an eye-opener for us because we didn't appreciate the prevalence of depression and anxiety in the adult individuals. And unfortunately, there does seem to be a subgroup of adults where anxiety and depression is so severe that it really is interfering with their daily lives. And I think we haven't addressed this properly. I think there's a great need to really look at the individuals who are over 30 years of age and to try to identify this. Again, it doesn't seem to be related to a galactose 1 phosphate level, you know, of a chronic nature, you know, nor does it seem to be directly related to how severe the problems were in the first month of life. You know, we've had some patients where this has been so severe that they actually have required electroconvulsive therapy, you know, for depression, and you know, the etiology of this, I think, is just not known. Annette or Stella or Stephanie, do you want to comment more?
Well, Steffi, go ahead.
First of all, I need to clarify that I only work as a pediatrician, so I do not see older patients. That's just by the way that I'm appointed here in a purely children's hospital. I just wanted to comment that I think it's really important that we look at the psychology of our patients actually quite early. You just mentioned possibly to explore patients above the age of 30. I have seen in even younger patients with galactosemia depression that I can even diagnose as a non-psychologist or psychiatric person. And I have forwarded or I've referred these young people that might be around the age of 14, 15, 16 to our psychologists to explore. And it has been confirmed and they got some additional help. So I think it is even possibly happening at an earlier stage that there might be the onset of depression. In regards of anxiety, when we have a clinic with galactosemia patients, a lot of the personalities are, or there are patients that have quite a similar personality, and anxiety is certainly there even at a younger age in some of the patients. So again, I try to look out for signs and symptoms, and I try to refer them even earlier, so to our psychologists usually.
Yeah, I agree with you, Stephanie. I just focused on the adults because it seemed to be a time when those problems can be incapacitating as they get older. But I agree. This is probably something that should be addressed in an earlier age. One thing I think it's worth talking about. I have an associated autistic spectrum disorder with galactosemia to a great degree. That phenomenon of being withdrawn and keeping to yourself, that's not really seen to be a characteristic of patients with galactosemia. But we have had a few individuals who have come under that classification in the recent years, but they're rare. I think there's, out of 150 subjects that we've been studying, I would say maybe 5 of them would fit that expanded spectrum of autism.
May I add something? What we've done in our cohort in our expert clinic in the past few years is examine really well the cognitive outcomes and also internalizing and externalizing problems such as depression and anxiety. And we saw quite a bit of depression and anxiety. And I think we've made a little bit of a start, I hope, with that by in a guideline stressing that young patients should be seen and tested by a psychologist to look at cognitive outcomes, but also at especially internalizing problems. And I hope that will ensure a better follow-up for patients. But I think we need to do much more in that area. What we did in our patients, do a standardized autism spectrum test. And we found that they had scores very much comparable to the normal population on those, but it looks a little bit more like it because of the internalizing problems. But I think we're just making a start, and I think the person asking the question is correct that we need to have more attention for that.
Yeah, and I do agree also on that for the EGS, because we struggle with it. We struggle with it even in one country, because we know that there are even within one country, north, south, east, or west of a country, the opinions are different, and it's not. It's more also a soft science than a hard science. So we are absolutely aware of it, also with cognition issues, and we still haven't found a way to deal with it, and that's also what, amongst others, why we're so happy with Clementine in the group as a psychologist. And we really need to reach out more in that area. So it's high on the agenda, but we struggle. So thanks for your question.
I also add something. We have also looked at that issue, not very detailed, but we have noticed that regarding the autism spectrum disorder question is that the problem is that we have sent several patients to that diagnostic workup, and they actually do not qualify for the diagnosis, but they definitely have autistic traits. So I think this is a typical problem of galactosemia, that there are certain chronic problems that fall between the labels. And so I think what we need is also to have more precise instruments to diagnose and to catch their problems. And for instance, for autistic traits, that we look more precisely into what they actually look like. It's not autism spectrum disorder. It's something similar, but there are differences too. And then also what Annette said regarding the neurology. Actually, since we have found in the registry that a lot of children have tremor, we look at it more closely, and we actually notice that we have missed in several children that they have tremors at an early age. But nevertheless, we also observe that the adults get more of it. And so there is something going on, certainly, even though it is a transversal look. It's not, in the follow-up, we can't say yet, we have not enough observation time.
So maybe to recap, I think that we can say that our awareness on anxiety, depression, movement disorders has tremendously increased the last years, and that will be for the coming years really important, because then we will be also taking care of, or just looking into these domains when we see patients. And I think that's also our task, that just to broaden the awareness to all physicians and teams treating these patients.
Okay, thank you for that. I think that's also an answer to the question of Bernd Beck. And my question is whether there's data on the difference between male and female galactosemia patients in adulthood in relation to psychological issues with depression and anxiety. I'm not sure the gender was discussed, if there's any difference there.
We didn't find any gender differences in this analysis that we have done. But that could change as more patients are included.
Okay, thank you. And also, I think we touched upon Suzanne's Gierlinger question. Do you have experience of fertility in male patients, and are many patients with tremors? No. Cynthia, I think this one is for you, because you, it looks like you set the alarm. It's the middle of the night now, or not, in the US?
Well, not quite. It's the same time for Dr. Barry as well. But yes.
Good to see you here.
So I can answer the part about fertility. Yes, we looked at male fertility, mostly because one, nobody done it before, but also because we got a little worried because we didn't see a lot of male patients fathering children. When we looked into it, we did indeed see that not so many adult males had children in the cohorts that we were looking at. But it doesn't seem to be related to their biological fertility. We did see a slightly higher incidence of cryptorchidism, so undescended testes on one or both sides. We also saw that there were some men who had slightly lower hormonal values, but all within normal limits, and some men had some abnormalities in their sperm. But none of that was to a level that we can say, oh, galactosemic men have to worry about their fertility as a group. So what I would recommend, if you are an adult man with galactosemia and you are trying to have a child, if it's not working spontaneously, I think it's good, just like the females, to get help and just have your sperm looked at, have your hormone levels checked if that is indicated. So I think as a group, you don't have to worry, but if there is a problem, then definitely don't wait too long, because there might be some relation. Oh, and the part about the tremors, I would refer to probably everybody else.
Is there anything known about the amount of patients? Does somebody know that by heart by looking at the registry?
With regard to the tremor, in the adult study we did, it occurred in about 45% of the adult individuals of a cohort of 33 people. I think in the US, the prevalence of a tremor has varied from between 20% of subjects to 45%.
That sounds significant, and we also recognize it with our daughter. When she was younger, she had no tremors, but now she's 20, and it's getting a bit worse. And it looks like it's related also with tension. So if she's a bit stressed, so if you ask a question, she will start trembling more, or if there's some pressure. And if she's relaxed, you won't notice. Then the question from Sue, I think that one is to Matthias. That's about your talk this morning.
Well, I agree to that. It is not quite understandable, but we have to know that there are different diseases that are in the newborn screening panels. So it's not just about galactosemia. That's one thing. And the countries are very different. So there are small countries and large countries, countries with an infrastructure that is very well established, and others that have a more difficult an infrastructure is more difficult to be very efficient for the newborn screening. So I think these geographical and economic differences, of course also the costs, they are, I think, important to explain some part, and objectively explain some part of the differences of the newborn screenings. But I very much agree that there are parts that are more difficult to understand, and I think that is the point where we want to come in and at least for the newborn screening for galactosemia, have a more consensus point of view for that, and have recommendations.
I see a related question from Elvira. Do we know what is the overall mortality rate among newborns with galactosemia if the diagnosis comes too late?
I do not know, but I suspect that it is difficult to ascertain, because when you miss a baby, then you may miss the diagnosis completely, and even when it has died, you may not know of what it has died. So he or she has died. So I don't know. Perhaps someone has approximative values about that. I don't. And I think at least I would think that in countries with newborn screening, I don't know of any child that has died of galactosemia, and the newborn screening result has come too late. I don't know about that, at least not in Switzerland. I don't know if anybody else knows about.
I think what might be relevant is that in our country, we have newborn screening since 2007, but the incidence of galactosemia has not gone up. So it isn't so that there were children missed before and that we find many more patients now. And I find that somewhat reassuring.
I don't think this has been studied properly. The one thing we know in the States is that now that it's a law that every state must screen for it, there are certain states now, particularly in the West, where they never had 1 or 2 patients with galactosemia each year, and now they do. So that speaks to probably a significant number of individuals who may have been just thought to have a bacterial infection and died, when in fact it was galactosemia that was the cause. But there's no good data to really speak about that intelligently. It just needs to be studied in a prospective way now.
Thanks for that. That's always difficult to know what you don't know. I have a question for Triviant, I think. Do you know the oldest living person with galactosemia in Europe or in the world? It's an interesting question. Does anybody know that in the registry?
Our oldest patient is around 65, between 65 and 70. Well, I think now approaching 70.
Anybody has a higher number?
Oh, the oldest patient known to me is also beyond 60. But
I feel like an auctioneer now. Can somebody get up above 65? So
and for these elderly patients, do they have more health issues than people of their age that won't have galactosemia?
in the one that I know of, that's the case, but we must realize that these patients were diagnosed very late and exposed to a lot of galactose in the first months of life, and that definitely has dramatically changed their phenotype, their clinical picture.
That's the same with our patients. We have two brothers, and they were diagnosed before the era of newborn screening, obviously. And that was around the same time as when the etiology of galactosemia was actually discovered in the mid-50s. So well, they have more problems than we hope, at least our future elderlies will have.
Thank you. I see another very interesting question from Antonio Vasquez to Professor Barry. Can you answer? Can you see the question? Or shall
Yes,
I?
Yes, I can see it. I think the question is asking, could we have better relationships among the U.S. Galactosemia Foundation, that's a parent organization, and their support for research and their interaction with other support groups and galactosemia parents in different countries around the world. I think that's true. I think we could all work together better in this regard. My sense is, as the years go on, that it doesn't make a lot of sense for us to be doing things from a research perspective where we're only looking at a very small group of individuals. I think what we need is an international organization so that we can begin to look at thousands of individuals with galactosemia to better understand their problems. And I think there's also an issue of, there's just only a certain amount of money that exists for research. And I think if we could try to work together and maybe coordinate our efforts, I think we could come up with better studies and maybe help patients in a better way. But the Galactosemia Foundation has been trying to become more and more accepting of having other individuals join, and I know that many of the individuals that are here today have actually participated in our parents' meetings, and they've helped support them and all. So I think this is a good thing, and we can do more of it. if someone has some ideas, I'd be glad to go to the president of the U.S. Parents Organization to speak with them about more partnership. Was there anything else in this question that I'm missing?
Not from my side, but maybe also to comment on our side. I think we also like to learn from as many other countries as possible. But as we're all doing a voluntary job as a patient organization, it's also a question of limited time and resources and things like that. So, but we really embrace this international cooperation. So we're really happy that that this is happening, and I could see that people from Australia, New Zealand even joined. We have 30 different countries already. I think America is a bit different, but maybe you can comment a little bit more on that. How many patients do you have in the US, for example, and are they covered over the whole of the US? And so is there, because we're talking about 1,000 patients in Europe, some parts better organized than other parts. Is that the same for the US?
Oh, the most recent estimate is that each year there is 80 to 100 new babies born with classical galactosemia, and the membership of the Galactosemia Foundation is somewhere in the 500 or so patients, but we thought that there probably should be more like 1,000 in North America. But one of the things that's unclear is whether many of these patients or families have not enrolled because they're doing well. And this always comes up as a criticism about our evaluations of what does all of galactosemia look like, because maybe only the people who don't do well are the ones that join the organization. But there's no good numbers really to say this with certainty.
But I would say that's another good reason for newborn screening, because then you know the total population at least, and then you can compare the ones who are doing good and are not doing good. Because I recognize that argument. Also in our local groups, we are often afraid that the people who are doing well do not join, or they will at a certain moment stop with that, and that we see only the patients who struggle most, which is very important, of course, but sometimes the view may be not completely right there, because you should also do good cases. So,
but if I may say, the problem remains, because we know there are out there patients who do very well, but we have great difficulties to get them in to participate in our studies, and these are the same who do not participate in the association activities.
But still, you know them, and that's already much better. So your data is better than the ones who don't know them, I think. But I do agree with you. It's more difficult to get in touch with them. We struggle with the same things in our groups.
Yeah, to give an example about how things can become so skewed. Years ago, when we looked at a cohort of individuals in the Children's Hospital in Philadelphia, of a group of 50 patients with classic galactosemia, we found that roughly 20% of those individuals had a tremor. But when we looked at a group of adults, it went up to 44% of this group of 33 individuals. So there was roughly a doubling of this, and I think it immediately makes you worry that the adults who participated in this study were the more severe ones, because that's a pretty significant jump. The other explanation is that the half of the patients in the first group were children, and the tremors didn't appear until you were 18 or 19 or 20 years of age. So the answer to this is not known.
Okay, thank you. Then there is the last question from Natalie, at least the last question that I can see here.
Can I comment on this one, Jerome? Eileen, Tracy here?
Yes, please. Yes, please. Hi, Eileen.
Yeah. Hi, so sorry, I was away this morning. So Natalie, so in Ireland, we have over about 150 patients with galactosemia, and 98% of those people have the same mutation, which is the common Q188R mutation. They've all had the same, many of them have had the same experience, that they started screening and on the same diet, but there is a huge variation in the outcomes in the groups. And for example, I talked yesterday about even in siblings, brothers and sisters that have the same identical mutation, for example, Q188R, there can be vast differences in how they get on in terms of their intellectual performance in adult life. And we have shown in our own studies already that in addition to the mutation, there are other significant variations in experience. For example, in prenatally, there may be different exposures to galactose and so on. But importantly, we have looked and shown that how the sugar chains are added to proteins and lipids are actually changing or different in these particular patients. So there's other ways to maybe bypass a little bit of the open pathway in some patients. And we don't know whether that really is directly related to the outcomes. Like, for example, we know high cholesterol is associated with heart disease, but unfortunately in galactosemia, we don't have the outcome studies long enough over time to know whether these changes that we have seen in these siblings are directly related. So we are continuing to do research, but it's what your experience would be very common, that people of the total identical background in the families and of the same genetic makeup can have huge variation in outcome. And that's the challenge, I suppose, in how do we predict the future? And it's something that the GalNet will be looking at more carefully over the next few years. Silence.
Thank you, Eileen.
Thank you. And then there's a question from Chris Powell. He says, I was late starting to talk and I've always been slow at speaking and found it difficult to join in conversation. In recent years, this has got worse. I know we had a research on speech some time ago, but speech was also quite a complicated animal, I remember.
Yeah, well, I think that this is a very typical complication of galactosemia and something that we see commonly. And although that it gets worse, it's not seen in the majority of patients. Maybe other panelists have experience on that.
Yeah, that seems to be an uncommon phenomenon. In my experience, it seems that patients with galactosemia learn how to cope with their disease better as they get older. That they learn to improvise, and I think even in the IQ test you see this. In our adult study, we had a mean IQ of 85, whereas a lot of the early US studies had mean IQs in the 83 range, 85 range. And I believe that the group in London found that same IQ of 88, and also the group in I believe Dusseldorf found it as well. So it seemed that in aggregate, the patients got better, were able to cope better as the years went on. But I do know there are exceptions to this, and I think this is a major problem of why there seems to be some deterioration in maybe a rare group of individuals that are over 30 or 35 years of age.
If I may add here, I think that the speech problems are also quite complex in galactosemia. So it's not just a problem to speak by itself, but we found that it is sometimes many of our patients even have very good passive speech capacities or language capacities, and the speech problems are predominant, and much is motor, but it is also part of the proceeding of the speech between the idea and the getting to pronounce a sentence properly. And then what Chris also says is to join in a conversation. There's maybe also a part of a social issue here, which we also often see. So it is really complex, and I think what Jerry said is also important, that during the time during life, these changes and part of their problems can be addressed and can improve because they learn how to deal with it. But other parts may possibly deteriorate in the course of life. But I think the problem here, and that is another point I would like to make, is that it is quite complex, and it may be a bit different in galactosemia compared to other common problems in the population, in the general population. And I think this may stresses the point that we not just need to have a lot of patients, we also need to address their problems very specifically. And one thing I have learned from this collaboration is that we have to be much more precise in our assessments.
Thank you for this addition.
I just a comment on Matthias's comment. I have probably seen about 50 adult galactosemia patients in the last 2 years, and our experience would be that the speech abnormalities or changes are very stable, in that we haven't seen any deterioration in our particular practice. But coming back to the point about the tremor, I think it's really important to note that, is this progressive? Because it does seem to be more in adults, or is it just that in adults that it's picked up, whereas it hasn't been noticed in children? And I think that's a really an important point that Matthias said, that we need to look very carefully. Is there progression of any neurological signs in collaboration in the group, and can these, be correlated with the ongoing studies that I know Annette and her group in Boston are doing in terms of white matter and gray matter changes? Because we haven't systematically looked at that. So I think we're all saying the same thing about the tremor. We just need to know, is that kind of like what's called a bias of ascertainment? Is it just that we're looking more carefully, and we need to systematically screen children and adults to see, is this changing over time? But the speech in the clinical experience for us, or the speech changes have been stable and static in our experience anyway. Thank you.
I would like to, I wanted to add to that we have studied language and speech, and I was glad that Matthias commented on this, but because I think that the motor speech is important and affected, but language is really complicated. And in our previous studies, we have seen that there are numerous phases of language that are affected in galactosemics, like syntactic planning and other things. And those are also the things that we need to give attention to. And as we learn more about this, then we can just translate that into our clinical practice. And I think that over the years, motor speech has been very much looked at, and the other aspects not as much, because they were just maybe less known that they were affected.
Yeah, I agree with Matthias and Lean, and I think it's confusing to be able to understand what different aspects of central nervous system dysfunction emerge at different times in the patient. I know myself with regard to tremor or movement abnormalities. I've seen a patient with this at 10 months of age, and other children, developing a tremor in mid-childhood, and one patient developing it at age 17 and have it progress over a couple of years and then remain static for the next 20 years, and then other individuals that have developed a tremor for the first time at age 35. I just don't think we have a good understanding of why this develops in certain people at certain times, because all of these individuals are classics I'm referring to. I think Estella probably has done the nicest work at looking at this with the MRI, the special studies that you've done, where it looks like the basic tracks that are being established in the brain are different early in life. You should comment a little more on that, Estella, about something that touches some more on a developmental perturbation than a toxicity that's happening later.
So, yeah, we have done some work on the neuronal tracts, identifying which neuronal tracts are affected, or to begin with, which ones are responsible for instance, some aspects of language. And when you compare that between galactosemics and controls, then you see that there are clear differences that point to that, for instance, galactosemic recruit more extensive regions. So the patterns look similar, but galactosemics need to recruit more neurons, for instance, for doing the same job and not being able to do it as well. And I think that's important to know that these affectations occur, and we see that in at different ages when we look into it. Is that what you meant, Jerry?
Yes, and I guess the thing I found most fascinating was the idea that qualitatively it looked like the tractography was different in the patients with classic galactosemia. In other words, it's not as if, let me just take a guess at this. It's not that galactose 1-phosphate and other compounds are causing damage to the brain, and you're resulting in myelin tracts that are missing. It's the fact that the way the tracks are assembled look different, as if your blueprint for establishing connections within the brain are disturbed, and it may be present very early in life, maybe even in prenatal life. But it seems like a stochastic phenomenon where it's quite variable, but qualitatively different in patients with galactosemia, classic galactosemia, compared to control subjects.
Professor Berry, if I may interrupt, we're coming close to the end of the webinar, but there are still some related questions. There's a question about, do we have any statistic on dyslexia and dyspraxia amongst galactosemics? And also a question from Bernd Beck. Would that mean that for parents it would be recommended to focus on teaching the syntax, grammar, etc.? Because it doesn't come to patients naturally. That maybe Estella can answer that, or Stephanie, I don't know.
What I can say about that is that that syntax and grammar and sentence structure deserves attention. So I think it's good to realize that those could be affected. Yeah.
Yeah, I think I have not to add anything more specific, but as Estella said, it's important to look at it in detail and then have the appropriate plans to help the individual with the problems, to have the tools in their hand, and as well the schools to understand how they can support the individuals with those problems. And our psychology teams, for example, write very specific recommendations for families and, for example, schools.
Okay, thank you for that. And there's a question about diabetes 1. Does it increase complications? Is there any specific additional care? And if there's a link between galactosemia and chronic bowel disease?
I can comment about the diabetes. I've been following an individual for past 20, 25 years, and he has classic galactosemia and also developed juvenile diabetes when he was about 10 or 11 years of age, and he hasn't seemed to develop any special complications outside of what we see in patients with classic disease. He's also become a father successfully ×2. So, but that's the case of 1.
There are many cases of 1 in galactosemia. And I think we come to an end of this panel discussion. And that's not a question, but a thank you. I also wanted to thank the panelists. I think we had a very good conversation. A lot of subjects were addressed. And I think it proves to a lot of people that lots of things are happening in galactosemia. And I would like to end with a few slides I prepared and give the final speech or the final word. Mirte wants to keep control because I make every now and then a mistake. And I was so happy that I could push the buttons I wanted, but now they won't even allow me the buttons anymore. But I'll deal with it afterwards, don't worry. So what I wanted to say is that I think the conclusion of this EGS-GalNet in these very special times, I think that yeah, we can all say that EGS and GalNet cooperation proves to be very valuable for patients and professionals. At least we are very happy with this, and I think we made great steps forward in the last 20 years. I also would like to say to the patients that the better we are organized and the more members we have, and especially thinking about the remark of Professor Berry, we also like to have the more healthy or the patients without too many problems, because it's also good for patients to see that, especially for young people, that yeah, although we don't understand all the difference and why they come, but it doesn't mean that if you have galactosemia that you cannot have a good outcome. So that's why we also try to reach as many patients as possible. And on behalf of the EGS, if there is no patient organization yet in your country, please reach out. We have the network. We can try to help you. We can try to help you with advice to set up a patient organization. The organizations in Spain and France are also relatively new. but they are doing a great job. The big countries, they have special complications compared to the Netherlands because we're a very small country. But we can help at least by sharing our experience and maybe some tips and tricks. Then the other thing I think is very important, that the international guidelines, they are available online. We have been discussing that. We are very proud that there are at least now international guidelines available. They're available on the EGS website, but also on the GalNet website. And I would like to emphasize that they are guidelines and they are not rules. So we're all individuals, and we don't need to do all the things that are in the guidelines. But if you have any specific questions concerning the things that are mentioned there, please take the guidelines to your doctors or dietitians and talk about them. And it will help getting the relation better as well, I think. Then I would like to thank everybody in the audience for your time and attention. Personally, I miss the audience and the interaction and the social networking, because also on the bar and during dinner and during lunch, all kind of ideas pop up and we can learn from each other. The other thing, the good thing is that we were able to reach many more people across the world. So that is the good thing about this. And I think it was a great opportunity to show the power of cooperation between patient, parents, and professionals. And then last but not least, a big thanks to all the speakers from the GalNet. You really made the webinar very interesting, and I believe it should be continued. And next year, I hope that we can have a hybrid meeting. So a combination of a group of people in one room, maybe with a good camera, and some people behind the computers to allow people from all over the world to join. And that will be the next level for next year. And I hope we can all travel a bit more to see each other. Thank you very much. Stella, the floor is yours for the final comments.
That's really what an honor. Well, I can barely add anything to what you already said. I just want to thank everyone, also a lot of people that has worked intensively to make this technologically possible, and all the people from the GalNet. Thanks a lot for your commitment, and all the participants, thanks for participating. And I would be really thrilled if we can organize an hybrid one for the next year. I think that would have a great added value. So I would invite everyone with nice ideas for the organization of the next one to just let us know. Also the subjects that are really interesting to you. Please give us your input so that we can make the most of it. Okay, and just reach out to any of us and we will get in contact to you. Thanks a lot. It was really a pleasure to be co-organizing this event. Thanks a lot.
You're welcome, Stella. And I agree, we go for hybrid and it will be the next level, and life must be a bit challenging. So we go for it. And then maybe a final remark about sharing the data. Like Stella said, you all got my email, because else you wouldn't have had this the link to the webinar. So if you have any remarks, questions, please share them with me. I can distribute them, and we'll find a way to make this available. We recorded all the sessions, but like I said in the beginning, we have to figure out where to put them, where to place them, and because just sharing PowerPoints without, yeah, so we just have to think about it. But don't worry, we'll share the information with you. And herewith, I would like to close the EGS-GalNet meeting webinar. Have a great weekend, and thanks for joining. Bye-bye.
Okay, thank you. Goodbye, everybody.
Bye-bye.
Thank you,
Bye-bye,
everybody.
everybody.
Bye.
Please do not stop the seminar now because I didn't save everything.
I learned from yesterday. Sorry for that.
Bye-bye.
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 Cynthia and
Yeah, I'll go.
thanks. Yeah, they'll already go.
Stop sharing.
Matthias, thank you very much. Eileen, thank you.
Now we're all alone.
Stop recording. Hoe kan ik nou, er zijn nou steeds 34 attendees. Hoe krijg ik die nou weg?
Nee, dat maakt niet uit, dat doen ze zelf. Kijk,
Ja, dat zeg je nou. Oh, ik ga even antwoorden typen.
Ja, heel veel thank yous, toch? Waarom zie ik die allemaal niet? Hier.
Hoe kan ik die nou antwoorden?
Ja, dat kan dus niet.
Ja, ik kan niet.
Ja, dat is